Good evening, everyone. Welcome. Thank you so much for joining us for this virtual UMiami Health Talk, Women's Health, addressing your most common gynecologic and gastrointestinal questions. I'm health journalist Ileana Bravo. I'll be your moderator for this evening's talk, which is presented by the University of Miami Health System's Women's Health Alliance. The Women's Health Alliance provides comprehensive women's care at every age, recognizing every woman's health needs are unique and they change throughout life. You can count on them to provide compassionate, personalized care across multiple healthcare needs. A unique differentiating feature is their women's nurse coordinator. This dedicated professional serves as a personal guide and advocate for each patient, helping them navigate the complexities of the healthcare system and to coordinate their care. So when you need a routine checkup and specialized consultation and treatment for specific conditions, they help coordinate it all. You can learn a lot more about UHealth Women's Health Alliance by visiting umiamihealth.org/all-women. We're going to put this contact info up throughout the whole time, so you can take a picture of your screen and it'll be up at the end as well. You can ask for a consultation and screening by calling 855-349-6636, which translates into 855-34-WOMEN. Tonight, you're going to hear from our women's health experts, Dr. Laura Martin and Dr. Morgan Allen Sendeshu Shane. They are going to discuss and demystify some of the most common gynecologic and gastrointestinal conditions, touching upon what relief is available for common conditions which are considered normal. So you should expect tonight to learn and to walk away with a lot more medical knowledge than perhaps you had to outline your next steps. At the end of the presentation, you're going to have a unique opportunity, and this is very special, to be able to reach out directly to our experts tonight in the Q&A session. You ask questions using the Q&A feature at the bottom of your Zoom screen. Take a second to locate it on your particular device. You enter the questions as you think of them. We're going to prepare them for our experts, and they will address them at the end of their presentation. So right now, it's my pleasure to introduce our first speaker, Dr. Laura Martin, who is board certified in female pelvic medicine and reconstructive surgery, and an assistant professor in the Desai Setti Urology Institute at the University of Miami Miller School of Medicine. She has extensive experience in reconstructive pelvic floor surgeries and in-depth clinical knowledge of these disorders. Dr. Martin is co-chair of the Comprehensive Women's Health Alliance at UHealth, and she aims to become a leader in clinical and surgical practice safety for physicians and to lead the way in providing a global model for pelvic floor care. So it is my pleasure now, and join me in welcoming Dr. Martin. Take it away.
Hi, thank you so much, Ileana. Thank you for that lovely introduction. So I just wanted to welcome everyone. We're so excited about the Comprehensive Women's Health Alliance and happy that you can all make it here with us tonight for this discussion. I'm going to be talking about some very commonly asked questions in women's health. And I just want to make sure that you know that this is just scratching the surface. So we're going to be going over these topics pretty briefly and quickly, but I did want to give you an idea of what treatments are made available to you and what we can offer at UHealth. And we can offer these things and beyond, especially within our new Health Alliance. We have a lot of partners that we're partnering with in other departments as well that can address the healthcare needs that you have. Okay, so first we're going to start out with vaginal irritation and vaginal discharge. This is a very common complaint amongst women. Vaginal discharge symptoms can be copious white discharge. It can be clear in nature, or it can be green. So there's a lot of variety here. A lot of times the discharge can be malodorous as well, but not always. And women will often experience pruritus or what is known as vaginal itching as well. And you can have swelling and redness in the vaginal area along with this discharge. So if you notice any changes in your discharge that are questionable to you, you should definitely consult your physician. I'm going to review the most common causes of abnormal discharge, and you can see some images here. The first image here is of the bacterial vaginosis. This is an imbalance in the natural bacteria that we have in our vagina. So Gardnerella naturally lives with us. That's the bacteria that's listed here. And when that bacteria overgrows, you can have that thin discharge, clear discharge with a fishy odor, and sometimes vaginal irritation as well. And then another common reason why women might have discharge is trichomonas. This is a small protozoa. It's something that's similar to a bacteria, but not exactly, but can overgrow in the vagina. And this is a sexually transmitted disease. And then lastly, I think most women are familiar with yeast infections. This is also known as Candida. And oftentimes when women have this condition, they have that thick cottage cheese-like discharge, along with a lot of the itching in the vaginal area. And you can have even scratches on the skin because of the itching and swelling that you get. And then also, I just wanted to make a mention that sometimes this discharge can be gonorrhea and chlamydia. These are often seen together and often treated together, and your partners do need to be treated as well in these conditions. So those are just a quick list of some very common reasons for vaginal discharge. So going over to the treatments. So first of all, we always want to have good vaginal hygiene. And what does that mean? Essentially, you don't want to do things like douching. Douching disturbs the normal vaginal flora that you have. It can cause imbalances. It can wipe away good bacteria. And also you want to be wiping front to back. Make sure that you're not sitting in wet clothes when you work out or when you go swimming. And then specific treatments, I'm going to go through each of those different disease processes that we just reviewed quickly and just talk about some treatment options. And some of these you might be familiar with. So for the yeast infections, you can use things like the Monistat over the counter. That's a cream, that's the miconazole cream, or oral fluconazole, which is also known as diflucan. And these medications are usually generally pretty effective in treating the candidiasis or the yeast infections. And then for bacterial vaginosis, we often treat this with something called metronidazole. It can be placed either vaginally or it can be taken orally. And also clindamycin is another option, and that's usually placed vaginally for this condition. And then for the trichomonas, again, this is a sexually transmitted disease. So you do want to have your partner treated as well. But the treatment would be the same as the bacterial vaginosis. It would be the metronidazole. And then for gonorrhea and chlamydia, again, we often see these together. That's why they're paired on your screen here. And you should be treated for both. So we give a shot. It's called Rocephin. It's a cousin of penicillin for the gonorrhea. And then we give doxycycline or azithromycin for chlamydia. And again, your partner does need to be treated. Now, when these conditions become recurrent, that is something significant. It depends on the actual disease process. But for example, bacterial vaginosis, about 30% of patients will have recurrent bacterial vaginosis. So it is something that you want to address with your provider. And we do have specific therapies and prolonged treatments for recurrent infections. All right, so now we're going to transition over to abnormal uterine bleeding. This is bleeding that can occur outside of your menstrual cycle, so spotting or bleeding in between menses. It can be an abnormally heavy menstrual period, or it can be things like having bleeding that's prolonged for an extended period of time. So for instance, if your menstrual cycle is usually 5 days and you have a period that lasts maybe 2 weeks. So these will be all examples of abnormal uterine bleeding. And we use this acronym that you see here. It's called POMCOIN. The P stands for polyps. And as you can see in our image here, this uterus, this is a nice little cartoon. We have the polyp for the P, and that's just a little growth on the lining of the uterus. Usually these are benign growths. Adenomyosis, this is a condition that many of you may not be familiar with, but it's when this lining of the uterus, it's called the endometrium, when these cells get into the muscle of the uterus. This can cause heavy bleeding and also pain, especially during your menses. So this condition is something that many may not be familiar with, but can be very difficult for patients to deal with because of the pain issue. And then also there are fibroids. That L is for, we call it leiomyomas, but it's commonly known as a fibroid. And you can see these little yellow golden nuggets here. They're inside the actual uterus. They can be on the outside lining and also on the internal lining of the uterus. And these are simply smooth muscle tumors. They can be found in other parts of the body as well. These are usually benign, and many women do have them. So these are very common, but when they get large, they can cause problems, including pain and heavy bleeding. And then, of course, there's always the risk of malignancy or cancers and hyperplasia, which is the beginning of cancer cells within the uterus. And you can also have heavy bleeding because of coagulopathies or problems with clotting off blood. So you can see that there are some blood vessels here. We have a vein and an artery. And when a woman has her menses, this lining on the inside tends to slough off. And that's what your menstrual cycle is, when this lining of the inside of the uterus releases. And if you're not able to clot that release, then you will end up having heavy bleeding. So if you have a clotting disorder, you're not able to stop bleeding, that could be a reason for abnormal uterine bleeding as well. And then ovarian dysfunction. So our ovaries do control our menses. Every month, a woman ovulates when she's premenopausal. And once that egg is released and it does not attain pregnancy status, it is released and the lining of the uterus does slough off. So if there's a dysfunction in the body doing this cycle once a month, then that can cause abnormal uterine bleeding as well. So that's a hormonal issue. And those hormones are controlled by the brain that speaks to the ovary. So if there's any dysfunction along the ovary to the brain and also to the lining of the uterus, then you can have that abnormal bleeding. And then there can be issues with the actual lining itself of the endometrium. So you can have something called endometritis, for example, which is an infection in the lining. And iatrogenic causes, iatrogenic just means that it's something that is outside of the patient. So for instance, this IUD here, intrauterine device, sometimes for some patients, depending on the type of intrauterine device, this can cause bleeding for patients. So that would be an example of something iatrogenic. And then we have not otherwise classified. There's just a black box there so that we can include every possible reason for bleeding. But one thing that would fit in this category is if you had a delivery and then you had a retained placenta, that could be a reason that's in the not otherwise specified. And then, so how do we treat these conditions? I'm not going to go through all of the treatments, but I just wanted to highlight a few that are quite common that we see often in the clinic. And for polyps, the mainstay is going to be surgical removal. Remember, that's that little growth on the lining of the uterus. So after that's removed, you can give hormone therapy like progestins to help prevent regrowth of those polyps. And then for adenomyosis, that's when that lining gets into the muscle of the uterus, causing pain and bleeding for the patient. You can use NSAIDs, which are things like Motrin and Aleve to help with pain control. Also, hormone therapy such as birth control can be used to help that pain and also regulate the menstrual cycle. And then this is an example of an endometrial ablation. Endometrial ablation, it just means burning the lining of the uterus. And when you burn the lining of the uterus, then it helps prevent that heavy bleeding. So that's also an option for treatment for these patients. Uterine artery embolization, I have an example of that coming up, but it's when an interventional radiologist takes a catheter and inserts it into the arteries that feed the uterus. And they block some of those arteries to help prevent overgrowth of these cells within the lining of the uterus and things like fibroids as well. And then the last option is surgical management, which would be a hysterectomy. Just need to go to the next slide there. Yep. And with fibroids, I know a lot of people have questions about the fibroids. So again, management here is going to focus on pain control and things to help with the bleeding. So the NSAIDs, again, like your Aleve and Motrin, are very good in helping control that discomfort. And then your hormone therapy is important for not only controlling the growth of the fibroids, but also preventing the heavy bleeding during your menstrual cycle. This next medication is called tranexamic acid, And this one helps to clot off the lining of the uterus so that you don't have that excess bleeding. So you wouldn't want to take this medication if you have any history of clotting disorders or blood clots. That would be contraindicated, and you do not want to take it while you're on birth control. So you'd have to talk to your doctor about this to see if you're a candidate for this medication. And then we also have two other drugs on the market. We have the gonadotropin-releasing hormone agonist. These are things like Lupron, and also the gonadotropin-releasing hormone antagonist. The antagonists are newer on the market for the use of fibroids and also for endometriosis. Now, both of these medications, they actually affect your hypothalamus. The hormone that's released from the hypothalamus is the gonadotropin-releasing hormone, and that hormone affects your pituitary, which is where those peptides are coming from to tell your ovary what to do. So by blocking the pituitary and telling the pituitary we no longer want to develop any hormones that are going to be affecting our ovaries, they can shut down that system. And so the patient is no longer going to ovulate and will go into a menopausal state. So these are not for long-term use, they're for short-term use because they do have the side effect of osteoporosis. And it will put you into a menopausal state. So you will experience hot flushes with these medications. But for some patients that have very severe disease, these are quite helpful. And then other procedures that we can utilize, again, this is the uterine artery embolization. This is the actual image here. So this is the artery going to the fibroid, feeding it. And then this is the catheter that the interventional radiologist will place. And you can see here that there are some beads coming out of the catheter, and these actually block the artery and starve the fibroid, which helps to shrink the fibroid, and therefore it's less painful and causes less bleeding. And then a myomectomy is simply removal of your fibroids. That's done surgically in the operating room. And then lastly, again, the hysterectomy, just removing the entire uterus for definitive care. And in regard to malignancy and dysplasia, for the dysplasia, the changes that could end up being a malignancy, we can use hormones to help reverse this process, and you do need to be monitored closely by your provider. And then for cancers, this requires surgery, chemotherapy, and or radiation. Okay, and then our next common topic, I know that we had a lot of questions regarding this one. So common symptoms of menopause. So obviously the hot flushes, this is a very hot topic, literally. Patients can experience night sweats in menopause, mood changes, low energy level, brain fog, insomnia, and also weight gain. So I wanted to focus here just on the hot flushes because we did have a lot of interest in this. The reason why they occur is because there are decreased estrogen levels that affect your hypothalamus, which is in your brain. And when that happens, you become more sensitive to temperature fluctuations in your body. And that's what causes the hot flash to arise. So how can we address this? Obviously, people are familiar with hormonal replacement therapy. Not everyone is a candidate for this. We do want to be starting the hormone replacement therapy within 10 years after stopping your menses. Generally, I start within 5 to 7 years, so I'm a little bit more stringent. And that's because there can be cardiovascular risk when you start it after that. And then non-hormonal therapy options, we have a new medication on the market. It's called a neurokinin blocker. It's Veozah. And this medication affects the brain and helps to regulate temperature in the body. And that's how it works. So this is non-hormonal. And then antidepressants can be used as well. Things like Effexor and Paxil are very effective in regulating your hot flashes. And then there are pain modulators like gabapentin that can be useful as well. And if none of those work, we do have some other options. I wanted to highlight things like acupuncture and black cohosh, which are naturopathic ways of dealing with hot flushes. Okay, and lastly, just to give you a quick review of pelvic pain. Chronic pelvic pain is defined as having this pain more than 6 months. So it's a long duration. So for a lot of patients, you might have pain for a few months, and it does need to be addressed. Any pain should be addressed with your provider, but we don't put you in this chronic category until you hit the 6-month mark. This is often associated with cognitive or mental, behavioral, and sexual and emotional consequences, because it does involve your intimate areas and also can affect your intimate partner relationships as well. And just a quick picture here, I wanted to just review the nerves that affect the pelvic floor. First, we have the pudendal nerve. This nerve is sensory and motor in the pelvic floor, and we can do injections into this nerve to help with patients who have pain. So I wanted to make a mention of that, but more so I wanted to have a look at the autonomic nervous system within the pelvic floor. You can see that it's extremely complex. It looks like a huge maze. And this is why pelvic pain can be difficult to diagnose, and why we really need to do a very thorough exam on patients to identify their areas of pain and discomfort. And it also is a reason why patients might have difficulty localizing pain and saying exactly what their symptoms are. And that's okay. And this is why, because those nerves are so complex within the pelvic floor. And so what are the causes of pelvic pain? So there's multiple different areas that we need to look at in the pelvic region. There are urologic issues, gynecologic issues, gastrointestinal, psychosocial, and also neuromuscular issues. So when you go to your provider complaining of pelvic pain, they should be doing a thorough pelvic exam for you to identify which area is most uncomfortable for you. It may be one of these, it may be multiple. But we need to address all of them. And I think the psychosocial is always important. There can be abuse that triggers pelvic pain. Things like sexual assault or major depression or anxiety can also trigger pelvic pain. And often there's a neuromuscular component. So we need to go ahead and involve our pelvic floor therapist in therapy as well for these patients. So all of these different areas should be evaluated. Okay, and how can we treat pelvic pain? Obviously, we know it's very complex, but it can be addressed, and we can improve your lifestyle and also your daily existence. And so I wanted to just focus on this first column here, the stress reduction. This is very paramount in helping patients deal with their pain and also overcome the pain itself and to improve. So yoga would be one way to help with stress management, meditation and prayer, regular exercise, dietary changes can also affect the pelvic floor, especially things like the bladder and the vagina. And also cognitive behavioral therapy is very helpful, as well as sex therapy if that's needed. And physical therapists, I refer to a physical therapist multiple times a day throughout my practice, because I do find that women have pelvic floor dysfunction very commonly, and this can be a source of pain and can be corrected and really assist them in improving and getting better. And then also trigger point injections. These are usually steroid and lidocaine injections that we can place in both the pudendal nerve and also the pelvic floor to help pain, as well as doing the pudendal nerve block. Remember, that's that nerve that goes to the pelvic floor and affects motor function in the pelvic floor, as well as sensory function. And then if none of those things work, we do have medications that we can try. And also, lastly, we have surgery and pain management that we can refer to. So all is not lost. There's a lot that we can offer. And there's usually a cause behind every illness, and we're happy to help find out what that is for you to get you on the path to recovery. So I just wanted to thank you all so much for joining the talk today. I hope that I gave you just some basic information, and we're happy to help you do a deeper dive into whatever disease process you might be curious about. So come and make an appointment at UHealth. And with that, I'm going to hand it over to you, Eliana. Thank you.
Thank you, Dr. Martin. I think it's kind of like the perfect women's night out where we get education. We are all coming together on a Zoom screen for our health. That's kind of a relief, I think. And so now we're going to turn it over to our next speaker. Let me introduce her, Dr. Morgan Allen Sendeshu Shane, a clinical assistant professor in the Division of Gastroenterology. So we've gone from gynecology to gastroenterology, all the things that we aging women care about. Dr. Shane is a Miami native who graduated from Barnard College before returning to the University of Miami Miller School of Medicine for her medical training. She has a clinical interest in motility disorders and women's health, with focused research in the area of pelvic floor dysfunction, as well as reflux and the microbiome. Dr. Shane currently serves as the program director for the Gastroenterology Fellowship Program. So we welcome Dr. Shane, and we thank all of you for continuing to send us your questions, because they're super interesting and we're going to get to them as soon as Dr. Shane does her presentation. Take it away.
Thank you, Eliana. So today we're going to talk about some common gastrointestinal symptoms, disorders, again, kind of scratching the surface. These are all issues that we all suffer from in various degrees throughout our life, but certainly experience more as we age. So starting with reflux, GERD stands for gastric esophageal reflux disease. It has two components. There's the acid component, which is just the acid content that's in your stomach that may be moving upwards. And then there's the actual retrograde movement, the movement of that gastric contents in the wrong direction. So you can get symptoms for varying reasons, one from the movement of material going the wrong way, or from the burning from the acid content. Reflux worsens with age due to smooth muscle laxity. I'm sure you've noticed if you've hit menopause that the quality of your muscle tone is not the same. And that is true across the board, from your arms to your insides to your pelvic floor. And that can certainly worsen reflux. Symptoms can vary widely, especially in women. Women often present atypically. You don't necessarily see this typical burning esophagus like you see on the commercials where people drink the antacid medication and it puts the fire out. Sadly, women don't really experience that to the same extent. Women can have other symptoms like dyspepsia, which is just kind of a funny feeling in your stomach where you just don't feel so great. Loss of appetite, nausea is an extremely common symptom. Throat clearing, amongst other things. Diet and lifestyle can play a big role, as well as additional medication management. So first and foremost, we always try to tackle diet and lifestyle. If we can chip away at your symptoms slowly with something that you're doing, you're certainly going to have better control and require less medication management and other interventions over time. The first thing to do is to keep a food diary. Everybody's symptoms are different. Yes, there are classic triggers like coffee or excessive caffeine, chocolate, tomato sauce, citrus fruits and juices, fatty and fried foods, and carbonated beverages. But that's not necessarily the case for everyone, and every patient has their different triggers. So the first thing you need to do is keep a food diary so you can kind of correlate what you're eating and the symptoms. Other lifestyle things that I think are important to point out include chewing gum, using breath mints, and drinking through a straw. Those three things require you to suck down more air, and that air has to go somewhere. So if it's not going down and out your system, it's going to come back up in the form of venting or burping. And every time you burp, that's another opportunity for those gastric contents to move in the wrong direction, leading to reflux. Also, we recommend patients stay upright for at least 2 to 3 hours. I am guilty of this as much as the next person, but the minute I'm done with dinner, I am slouching on the couch, laying down, probably half asleep. That is terrible for our reflux, because we really need to rely on gravity to hope that some of those gastric contents can empty downwards and take the pressure off that esophageal area. And then finally, lots of people drink a lot of water before bed, but your stomach doesn't know what you're putting in there. So any gastric distension from air, from food, from liquids produces gastric acid. So when you drink a lot of water, it triggers your body to produce acid, and then you lie down. And when you're anti-gravity, again, more opportunity for fluids to go the wrong direction. PPIs are these proton pump inhibitors. Those are the Protonix, Prilosec, Nexiums of the world. They are overwhelmingly safe. I know there is conflicting data, especially out there in the ether. The scientific data is there. What I like to tell people is that the FDA approved them for over-the-counter. So they assume you're going to take them wrong. They assume that you're going to take double the dose, and they're overwhelmingly safe. Sure, there are side effects to every medication, and you need to be monitored. If you find that you're needing these medications with frequency, you really do need to reach out to your healthcare provider to discuss them. But they are overwhelmingly safe. They only have two main risks over time, which include a decrease in bone mineralization, meaning that your bones can be thinner. So we always recommend patients take calcium and vitamin D. My favorite calcium trick is Tums because it helps with your reflux and provides a calcium supplement. And these are really for people who need medications daily because they experience symptoms the majority of days of the week. 4 or 5 days a week really requires a preventative medication. If you're a 1 to 2 time a week, maybe if you're eating what I like to call, our dietary indiscretions, things that we know give us trouble, but we like to have them anyway, mine is pasta. You can take these medications that are available over the counter, like Gaviscon, Tums, Alka-Seltzer, Pepcid. All of those are available as needed and can be used even prophylactically when you know you're gonna be straying from foods that generally are safe for you. The next thing I want to talk about is a change in bowel habit. It happens to everybody. It happens to everybody at varying points in time. If you've ever been pregnant, I'm sure you notice changes. I'm sure you notice changes with your menstruation. Oftentimes during ovulation, patients can become a little more constipated, and then during actual menstruation, you can have more frequent, looser bowel movements. That's all normal. So no surprise is that when you enter menopause, when your hormones change, those bowel habits can also be thrown off. You can also have issues with travel, antibiotics, other viral illnesses can throw you out of your normal routine. But when do you see a doctor? It's when those changes are persistent. If you are a little backed up, you take an over-the-counter laxative and it's not getting better, that's some time where you need to find your physician. Any blood in the stool automatically needs to be addressed, and certainly chronic changes in the stool caliber. If your stools are starting to get thin, that's something that needs to be addressed. And what is constipation? Constipation is wildly common. In fact, it's so common that there's an entire aisle at CVS devoted to laxatives. And truthfully, if the same thing worked for everybody, I probably wouldn't have a job. We have to kind of figure out what's the right thing for you once we determine that there's no other underlying issues that need to be addressed. There are hormonal issues, endocrinology issues like thyroid disease can lead to constipation, and that needs to be addressed. So all these things need to be looked at. But once we've decided that you just have constipation, we dive a little bit deeper. This is the Bristol stool chart. If you come see me in clinic, we will go deep into this chart and figure out where you fall and how we can get you managed. It's very common to need a stool softener with age. It does not mean there's something wrong with you. It does not mean there's something wrong with your intestine. It is just the natural progression of motility. As we age, our hormones have changed, our overall motility in our bodies, we move around less, which leads us to have a little bit more constipation. Chronic constipation is a big risk factor for pelvic floor dysfunction, which is something that needs to be addressed. And it can also be related to other pelvic organ prolapse. So if there's any concern about pelvic floor dysfunction, or if you've been on laxatives and they're not working, that's a time to see somebody. And then the other flip side of when your pelvic floor isn't working, either the door to the outside world is not opening appropriately, which leads to constipation, or it's opening too often, which can lead to fecal incontinence. It is extremely common, but less than 7% of patients with fecal incontinence address this with their provider. This is something that you should absolutely bring to your provider's attention. This is not necessarily a normal part of aging. It does happen as we age, but it does not just need to be something that you accept. If this is something that's happening to you, go find somebody who can help you with this. It can happen with or without warning. Sometimes there's an urgency and you just can't make it to the bathroom on time. It can be large or small volume. Risk factors include having been pregnant multiple times. If you've ever had an episiotomy, which is where they cut your pelvic floor muscles during delivery to assist with delivery. If you had a vacuum or forceps assisted delivery, that can also increase your risk of pelvic floor dysfunction. Chronic constipation. If you've been struggling with constipation since your childhood, teens, and 20s, your muscles have been doing and learning the wrong thing for a long time. And truthfully, they can compensate for a long time until once they just can't. Other perianal surgeries and other certain health conditions like rheumatologic diseases and neuromuscular disorders. How do we manage it? First, we need to diagnose it. Patients should get a colonoscopy. We do anal rectum manometry, which is a catheter-based test here, which measures the strength and coordination of the pelvic floor. Sometimes we do an MRI defecography, which looks at the relationship of the other pelvic organs to each other during the act of Valsalva when you're pushing down. And then we treat it by doing kind of a multi-pronged approach, managing your stool consistency. Sometimes it's laxative, sometimes it's managing your diet with increased fiber. Pelvic floor physical therapy, similar to Dr. Martin, I rely heavily on this group. Biofeedback therapy, basically retraining your body to do the right thing, because if you could do it yourself, then you wouldn't need our services. And then finally, if fecal incontinence continues, despite all these other measures, there's an option for an implantable sacral nerve stimulator. So let's talk about these dietary changes. You need a mix of soluble and insoluble fiber in your diet. One type is not enough. You can't get away with just eating oatmeal in the morning. That is not sufficient. There's lots of different types of fiber. Basically, any fruits and vegetables, nuts, seeds, they all have different types of fiber, and you need a good balance. Fiber supplementation may be helpful for some, especially those who may have an imbalance in the types of fiber or a paucity of the type of fiber in their diet. But beware of bloating, especially if you're very bloated. Fiber supplements can sometimes make this worse. So now, hot topic includes probiotics. What are probiotics? They are live microorganisms that are consumed and are intended to maintain or improve the normal microflora in your body. Basically, we are more bacteria than people cells, and we need a good balance of the good and bad bacteria in our gut. And sometimes, despite our best efforts, that bacterial balance can be off kilter. But we don't recommend probiotic supplements. There's actually no great data to support them. There's good data against them, especially in patients with constipation. Probiotics have been shown to lead to brain fog and bloating. There are but we do recommend foods that are naturally rich with probiotics. So that includes yogurt, kefir, sauerkraut, tempeh, kimchi, basically anything that is naturally fermented. Your body knows what to do with it. It allows these bacteria to set up shop in the right place. That's not to say if you take a probiotic supplement and you personally find benefit from it, I'm not going to tell you to stop it, but we don't recommend starting it if it's not part of your routine. And then prebiotics are just certain types of fiber that promote that good, healthy microbiome. And there are certain types of foods, including garlics, leeks, onions, asparagus, bananas, cocoa. You're all welcome for that. You get my permission to eat your chocolate. It is really beneficial for promoting a good, healthy gut microbiome. So there are just some quick takeaways. Your GI tract changes throughout the years. Every year you have to reestablish what's normal for you. It's not always going to be the same. And just because something was the certain way 20 years ago does not mean that that's going to be continuous. When you do experience changes, you need to bring them to the attention of your provider. That's what we're here for. It's our job to decide what's important. And if you're struggling with anything, bring it to our attention. We'll help you navigate that, whether it's diet, medication, therapy, other interventions, some combination. We'll get to the bottom, pun intended, of whatever's happening with you. So that's the end of
Okay. All right. So we have so many questions that we're going to try and take this in a sequential order of both specialty areas. So why don't we go right into natural, healthy ways to manage perimenopause and menopause symptoms? Because of course we speak of HRT, hormone replacement therapy. How about some healthy ways?
Yeah. So well, I don't want to say healthy ways because HRT is healthy for a lot of patients. So I don't want to phrase it that way, but naturopathic ways. So what are some naturopathic ways that we can, work and help menopausal symptoms? So having a healthy, well-balanced diet is always crucial, and regular exercise. So if you can do 20 minutes a day of cardio, and about 3 to 4 days a week of strength training, and incorporate those. That is excellent in managing your hot flushes, as well as the black cohosh can also assist. That's a medication, it's a supplement that you can just buy over the counter. And you can take it twice a day. And then also looking at acupuncture and stress reducing activities like yoga and meditation are also very helpful.
Okay, perfect. Dr. Shane, let's talk about a lot of the questions really are about IBS, and is IBGard contraindicated? Is it something that people are safely able to take?
Sure, great question. So IBS is an alteration in your bowel habits that is accompanied by consistent pain. It's normal to be uncomfortable if you're constipated, but that's not really what IBS is. There's certain criteria, and you should go to your gastroenterologist to get a full diagnosis. But in terms of things that can manage IBS, there's tons of medications, including over-the-counter and prescription medications. But over-the-counter IV Guard is encapsulated peppermint oil, and there is phenomenal data on the use of encapsulated peppermint oil for abdominal cramps in IBS. It helps restore the gut barrier. It helps with smooth muscle relaxation. It also decreases the transmission of pain signals into the body. So there's really no harm. Some patients do get some reflux type symptoms. So dyspepsia, upset stomach, and reflux. If you're one of those people, obviously this is not for you. But there's a very low risk in trying it. The number needed to treat, meaning how many people need to try it in order to get benefit, is 3. So one in every 3 patients finds benefit from using that supplement, encapsulated peppermint oil.
Okay, here's one that maybe incorporates both specialties. I've always heard that as a woman, I need to limit my consumption of soy. Is the consumption only encouraged if you're in menopause and trying to decrease hot flushes? So soy for bowel and soy for hormones.
Yeah, so I'll answer obviously for the hormones. So yes, soy supplementation can be utilized as well, and you can use that in place of HRT. But again, these soy tablets and things like that are not FDA regulated. So you never know what you're getting and how much exactly you're getting. So, you can use it if you're doing well with it. I think that that's fine. But if it's not controlling your symptoms, then you should definitely address it with your provider.
All right, so let's go back to hormone replacement therapy. I think that this was a great question because we all think this way. How long are you supposed to take it?
Yes, that is a great question, Ileana. So, there initially, back in the 70s and in early 80s, the level of hormone replacement therapy was quite high that people were utilizing. Now we use a lot lower dose. So the adage is to use the lowest dose possible for the shortest duration. But if you're still having symptoms when you come off or try to taper off of your hormone replacement therapy, there's nothing that says that we can't safely continue that for the patient, no matter what age, as long as they don't have any other cardiovascular risk factors.
So it was then the way it used to be treated with hormone replacement therapy versus now, and that's
versus
the big
now. Yeah, so our theory is a little bit different now than back in the day.
All right, pelvic pain. A patient asks, pelvic pain after walking, is that normal? Is it common?
Yeah, so I experience this question a lot. It depends on what the patient's symptoms are, but there are a few reasons why this could be happening. This could be a pelvic floor dysfunction, meaning that there's something physiologically happening with the muscles of the pelvic floor or the way that the person is actually walking that's inducing the pain, because things can be misaligned. But it could also be vaginal dryness. And after a lot of activity, especially for the postmenopausal women, when they have that vaginal dryness, that can also cause pelvic pain, irritation, and vaginal irritation. And that I often see. So there could be a few reasons why this could be happening, but no, it's not normal and it should be addressed.
All right, Dr. Shane, stool softeners, is it safe to take them regularly? And let me go ahead and envelop the rest of this question with omeprazole also. You might as well grab all of these. This would be for, the irritation and so forth. What's safe and how long should you be able to take it?
So I think a good rule of thumb with all medications in general is to take the minimum effective dose. It is totally fine to need medications to help assist your body with natural functions, but you should not be overusing it and you should not be taking it with excessive frequency. So with PPIs, omeprazoles of the world, if you're having symptoms 5 to 7 days of the week, then yes, you should take that medication daily to prevent your symptoms. And it is safe to take it long-term, as I covered in the talk, but you do need to supplement with calcium and vitamin D, and it's important to take it at the lowest dose that controls your symptoms, which can be escalated and de-escalated depending on the severity of your symptoms. In terms of stool softeners, everyone is going to need one at some point in life. I've yet to find someone who's not on one later in life. And yes, there are different types of stool softeners. The ones that are most beneficial and easiest to take are called osmotic laxatives. Basically, it helps to pull water into the intestine. So these are like the magnesiums, milk of magnesia, Miralaxes of the world. Those are all, the Dulcolax chews are magnesium based. Those are all fine to take daily. All they do is help soften the stool. It does nothing for the motility of the gut. It's not increasing any contractions. It's just helping lubricate the stool so it travels more easily through your system and makes it easier for you to evacuate. Senna-based products, those are usually in teas, and you can buy Senna over the counter. Those are natural irritants to the colon, and we don't really recommend them long term. They can cause some staining in the walls of the colon, and your body also develops a resistance to these medications, so you need to use more and more in order to achieve the same effect. So for the different types of laxatives, again, if it's something that you're taking regularly, you should really speak to your doctor about what's right for you.
All right, let's talk about brain fog, the cognitive decline. What's normal? What isn't? What treatments are available?
Yeah, so when women go through menopause, they can experience that brain fog, and using either hormone replacement therapy or one of the antidepressants can be very effective in treating this, and also cognitive behavioral therapy and doing your exercise and healthy dieting can also help your brain function. So those things can be addressed. And if you feel like there has been a shift in your mentation, certainly talk to your provider about it. We want to make sure that there's nothing else going on that could be more serious and that this is just a side effect of menopause.
Okay. An aging woman in our audience tonight says how to deal with vaginal dryness due to aging in the 70 to 80 year category, affecting sexual interest, of course, irritation, painful sex, etc. How do these?
Yeah, so this is a great question. So we have several ways that we can address vaginal dryness. Oftentimes when we address the vaginal dryness, it can improve libido as well. Not always, but it can help. So we can use estrogen replacement cream just for the vagina. That doesn't get absorbed into the bloodstream, so it's safer to use for a lot of patients. We even have patients who have had breast cancer that can use this product to help to relubricate the vagina and also help the collagen regrowth in the vagina. And then we have other things like coconut oil that you can use on a daily basis or argan oil to help with moisture, and also hyaluronic acid, and all of those things are over the counter. So those things can be utilized that are non-hormonal for patients as well. And then to address the sexual interest for women, their sexuality is quite complex. It has to do with their intimate partner, things that you believe about your own self, your body image. Religion is often involved, your social status, if you're under a lot of stress, taking care of your family, things like that. So it's very complex for women, a little bit more so than our male counterparts. So going to a sex therapist is often very helpful for this once you find out that everything physiologically is normal.
Right, Dr. Shane, colonoscopy. If a family member had colon cancer, obviously that person is going to be in a higher risk group. When should that colonoscopy happen? And I know that they've lowered the age of the guidelines, right?
Great question. So we lowered the age from 50 to 45 2 years ago. And so colon cancer screening for somebody who's of average risk, meaning no first degree family members, should start colon cancer screening at the age of 45. If you're having any symptoms, change in bowel habits, bleeding, that becomes a diagnostic procedure. That's not for screening. But in someone who's asymptomatic with no other family members with colon cancer, you can start screening at 45, and there's an option of the stool testing, which is for early detection, similar to a mammogram, where you do stool-based tests and we pick up advanced polyps and early cancers. Or you can do a colonoscopy, which is both diagnostic and therapeutic, in that we can go in and remove polyps that aren't necessarily problematic in the moment, but could turn into cancer in the future. That's at 45 for the average risk patient. If you have any first degree relatives, so that means a parent or sibling who's developed colon cancer in their lifetime, you start at age 40 or 10 years younger than when that first degree family member was diagnosed. So if that first degree family member was diagnosed at 55, 10 years before that would be 45 for you, but 40 comes first. So it's whichever comes first, age 40 or 10 years. If you have a family member who's diagnosed at 42, you'd need to start screening at 32, which is 10 years before. That's why colon cancer screening is so personalized, should be discussed with your primary care doctor. If you're at increased risk and you need to see a gastroenterologist, that's what we're here for.
And let's continue with you, Dr. Shane, on IBS, on the irritable bowel syndrome. The FODMAP diet, which I know is an acronym for a very restrictive diet, is it helpful for IBS, and is it sustainable for a long period of time for someone to be on?
Excellent question. So dietary recommendations are so personal. There's so much information out there, and you really can't generalize diets to anybody. Everyone's microbiome is different, everyone's culture is different, everyone responds differently to different foods. But the FODMAP diet is it stands for it's an acronym for a really long version of a lot of different types of fiber. But if you're very strictly following the FODMAP diet, it removes about 180 foods from your diet, lots of fruits and vegetables, things that are healthy for us overall. It's not really sustainable because it's really difficult to remove all of those foods long-term from your diet. But if you're really struggling from IBS, starting with a low FODMAP diet to kind of help reset your gut, lower your symptoms, and then slowly work with a dietitian or your gastroenterologist to reintroduce foods would be the right strategy. I wouldn't recommend a strict low FODMAP diet long-term for anybody. But certainly in the short term, it can absolutely help to relieve symptoms that are severe.
Dr. Shane, does alcohol, the use of alcohol, also irritate the bowel and the digestive system as we age?
Absolutely. Any alcohol affects your ability to digest certain foods. It affects your microbiome. It really does change the bacteria that live in your gut. I'm sure everyone has noticed if they've had consistent drinks or had too much to drink, it makes your stools extremely loose. That is a way for your body to move the alcohol out. If the alcohol actually draws water into your intestines, similar to the way some of those laxatives I described. So yes, it can change your bowel habits, and excessive alcohol use can change your microbiome. Rare social alcohol is certainly appropriate. There's the guidelines say 1 drink for women, 2 drinks for men daily are generally safe, but again, generally doesn't necessarily apply to everyone. So it's important to personalize these kinds of recommendations.
All right, Dr. Martin, let's talk about fibroids. This question is, would an ablation help prevent future fibroids?
Sure. So ablation is used to help control bleeding. It's the burning of the lining of the uterus. So it doesn't have any direct effect on the fibroids themselves. So this is the acting on the fibroid itself is not the point of the ablation. The ablation is just to burn the lining so that you don't have that excess bleeding. So no, it would not affect future growth of fibroids at all, and would not affect current size of fibroids. An endometrial and a uterine artery embolization, where the interventional radiologist places the catheter into the artery and then releases the beads to block the artery, the blood supply that goes to the fibroid, that can diminish the size of the fibroids. But it would not affect future growth of fibroids.
Yeah, which you had in your presentation, which was very interesting. But again, I guess ablation is still that conversation that's out there for those.
Yeah, because some people will get that procedure done that have fibroids, but really it's just to burn the lining.
All right, let's talk hysterectomy. This question is it still taboo? What's the minimum and maximum age to have a hysterectomy?
Yeah, so I really like this question because it kind of leads us to the social life of a hysterectomy. We think about it so clinically, but patients do have concerns socially. And I think this question is alluding to your sexual desire after hysterectomy and also orgasm after hysterectomy. So there's no evidence that it prevents sexual desire or any sexual dysfunction after your procedure is complete. The thing that can affect your libido, however, is if you have the ovaries removed. And if you're not on hormone replacement therapy after, it can affect your libido because you go into a state of menopause. If you are premenopausal, that could affect your libido. But there's no taboo. And as far as the age range, if you are a candidate for the hysterectomy, there's a reason for you to have a hysterectomy, then you can have one, whether you're, in your early 30s for some women, which is unfortunate, but can happen, up to 100.
Well, there are still questions coming in at us. The good news is for the people, the registrants, the 200 people on with us tonight, is they can reach out to your offices directly for consults to come in. A lot of these matters are private, obviously, so it would be better one-on-one. And the other thing for the registrants is that this whole talk is going to be sent to you afterwards. You're going to receive it in your inbox, and there was a taping of it being done tonight. So we are so grateful to our two experts tonight for being the privilege of their time. Dr. Martin, Dr. Shane, we thank you so very much for being with us tonight. To our audience for being so attentive, because we at the University of Miami Health System appreciate your participation. There's your screen again, umiamihealth.org/allwomen for more info. 855-349-6636 to make an appointment. And please fill out the survey at the end to provide your feedback and tell us more topics that you'd be interested in the future. Ladies, thank you for a wonderful women's night out, sans alcohol. And we will see you all in the future. Everyone out there, please stay safe and healthy. See you next time.